I'm Dr. Rahul Dhope. I am consulting diabetologist from Pune. I work with Dr. Dhope Diabetes Clinic and Thyroid Clinic and Jupiter Hospital in Pune. Today, I'm going to discuss some aspects of diabetes therapy with Dr. Varsha, and she is endocrinologist working in Pune. Uh, okay, so basically, see, as you all aware, diabetes is increasing in worldwide, and more so in our population, that is India. We are not diabetes capital of world because China has that dubious distinction of having more number of patients than India. But the patients who know about their diabetes, that is half the number of patients of diabetes, they don't know that they have diabetes. So that is why diabetes is very, very big problem in India. When we were studying diabetes in 2004 and 5, at that time we were having only 3 to 4 drugs at our disposal for treating diabetic patients. So we were having like metformin, then glibenclamide, and then insulin. So but after in last 15-20 years, what has happened, there are so many new classes of drugs have come up, and because of this the diabetes treatment has become so much exciting and interesting. So in last 15-20 years, now there are 2 to 3 new classes of drugs they have come up, and these are very, very exciting molecules. And we will like to know much more about them and their combination from Dr. Varsha. So I'll ask Dr. Varsha first question. So if you like, you know now these two things are very, very good, and together they are better. Like super additive or additive effect is seen for not only for HbA1c reduction but for kidneys and for heart and other many, many parameters like liver and other things. So how will you guide your peers to choose the patient profile who would derive the optimum benefit from this combination?
Yes, yes, understood. So, basically, which would be the ideal patient to use this FDC of SGLT2 inhibitor with DPP-4 inhibitor? So, I think I would split that question into two. So,
Okay.
one part would be where I would be talking about the glycemic parameters. So, ideal patient would be having, suppose if I'm talking about a treatment naive patient and comes with a HbA1c of around 9. Okay, and at that time, I want this patient to be on multiple drugs. I can't work with metformin alone with a HbA1c of 9. And want to give the patient early benefit so that to have a good glycemic legacy. And so I would like to start this patient on a combination of metformin and a FDC like this, which will help me to bring the patient's sugars down immediately. So this can be one scenario. The other scenario could be that, so suppose if the patient is not tolerating metformin or metformin is contraindicated, then even in a drug naive patient, we can start off or initiate the combination as the first drug if metformin is not tolerated. Then, suppose if the patient is already on metformin full dosages and is being uncontrolled, then yes, I would like to add this as a second line agent, this FDC there. Or maybe we could be having patients who are on metformin with SUs, or patient who is already on say insulin but requiring very high dosages of insulin, where you want to have some amount of reduction in the insulin resistance, and where this combination can help you in reducing or lowering the requirement of insulin of this patient. So these could be the different glycemic parameters which can determine my drug usage. The other part of my answer is actually based on the extra glycemic advantages. So suppose if I have a patient who is obese, okay, so and I want this patient to lose weight. So a combination of metformin with SGLT2 inhibitor and DPP-4 inhibitor would be an ideal combination to have weight loss and not to gain weight. So a obese person is a right candidate. Then a patient who is say is at a high cardiovascular risk, so the patient has got multiple risk factors for developing ASCVD, or if the patient is having micro or macroalbuminuria, is at a high risk of developing chronic kidney disease, then such a patient, if the HbA1c is already to the tune of 8, 8.5, and where you know that only metformin or SGLT2 inhibitor will not work, then in such patients, when we give this combination, we will definitely be able to reach our A1C target and plus give the patient this extra glycemic benefits of this combination. Anything else that you would like to add, Dr. Rahul? I mean,
Yes, basically, see, you talk about this extra glycemic effect. So basically, because of this combination, see, SGLT2 inhibitors, they are known to cause weight loss. So one thing is that there is weight loss in this combination. Then it has also got very good effect on kidneys and liver, and then heart. Then there is a BP decreasing effect of SGLT2 inhibitors, and then there is durability is also there. So you can use this drug at any point of the diabetes pathophysiology or diabetes history, like say at the start of the diabetes or maybe after 20 years after diabetes diagnosis also you can use. So this extra glycemic effects of SGLT2 inhibitors and as well as DPP-4 inhibitors, they are very supposed to be crucial for using these drugs in almost all patients of the diabetes.
yes, actually, I forgot to mention one thing where not to use. I think that is also one point which we all should emphasize that
Yes.
in our sometimes when we all come across a drug which can reduce the insulin requirement of a patient, sometimes we can go extra overboard, in treatment, and we may reduce the insulin of our patient too fast, and that may not be the right thing to do. So basically, elderly, frail patient, cachectic patients where you suspect insulinopenia, then be very careful about addition of this combination. So there, I think, what do you feel? I mean, we
Yes,
should.
yes. So basically, if the patient is insulin-panic, something like type 1 diabetic or maybe after say 25 to 30 years after diagnosis of diabetes or maybe very old and frail as you explained, in those patients, if you cut down all the insulin and give only SGLT2 inhibitors and DPP-4 inhibitors, what happens? This patient can go into ketoacidosis, and that is not very high blood sugar ketoacidosis, but normoglycemic ketoacidosis. And then the patient and see, when the sugar is not increased, then you may not get suspicion of diabetic ketoacidosis. So this patient might develop ketoacidosis and they will be underdiagnosed. So
Yes.
your concern is very well taken here, ma'am. I think everyone should understand where to use, and that is one of the very important aspects. Also, if patient you do creatinine, if the creatinine is less than or rather eGFR is less than 40-45, then you need to start this drug very very cautiously. That is also one of the things. Though
Yes, yes.
the GFR is coming down like maybe up to 30 to 35 also they are saying, but still in this practice I would like to start with very very caution, so that the patient should not go into typical dehydration and not develop acidosis and other
Agreed,
problems.
agreed, agreed. Very well brought out. So, I mean, I think this is a point which we all need to understand that books and clinical trials will all take patients as low as EGFR of 30, 35. But we in our practice we see that our patients just come to us for a follow up and then are lost to follow up for another 6 months, 80 months. They just continue with your same drug which you have prescribed, and in
Mhm.
that whatever time, what God forbid, if the patient suffers from say some acute gastric ailment or whatever, and the creatinine then suddenly jumps up or the EGFR drops down and the patient is actually not coming to you for follow up, the patient can land up with the complications. So definitely, when the EGFR is on the borderline, we should be careful and we should emphasize on regular follow ups with our patients. One
Yeah.
important point I think, which Dr. Rahul, I think you said, was about the use in chronic liver disease patients and in so where this combination can be used, EMPA and LINA.
Also, see, when you are using this drug, you need to educate the patient very well, because what are the risks involved while taking this combination? You have to tell that patient, like genital health and other things. Also, when patient develops some acute problems like fever or some surgery or something, you have to tell the patient that they need to stop this drug at least 1 to 2 days prior to that. Surgery or some. If there is fever, then the patient can stop at the time of fever. And then patient need to do their blood sugar regularly and if blood sugars are on higher side, they should use something else other than SGLT2 inhibitors for getting sugars under control. What do you say about that, Dr. Varsha?
Yes, yes, agreed. So I have had patients who have been admitted in ICU with prolonged ketosis just because
Mhm.
that when they were sick, they did not discontinue the SGLT2 inhibitors. So I think that is a very valid point, and we should all educate our patients about the right use of these drugs.
Okay. So now coming to the last question of this discussion. So what are your clinical experience with Empalina FDC and rate of observed incidence of hypoglycemia while using this combination?
Yeah, so my clinical experience with this combination has been really good. I have used it mainly as a add-on to metformin, or as where I want to reduce the pill burden of the patient. Sometimes even when combination of metformin is used and as a third line agent there. So I have seen that it helps wonderfully in terms of HbA1c reduction. There is no hypoglycemia. I haven't come across hypoglycemia just when the three drugs were together without SU. Yes, with SUs there have been episodes of hypoglycemia, and that has been only because the SUs were not titrated properly.
Absolutely.
But otherwise, not many hypoglycemias. One thing, Dr. Hawla, which I want to discuss with you also is that when I was reading, I came across this literature that says that suppose you have a patient who is only on a DPP-4 inhibitor, and then you convert this patient from DPP-4 inhibitor to a FDC of DPP with SGLT2 inhibitor, then you would get a more HbA1c reduction than you would expect in a patient where you are adding this FDC to baseline SGLT2 inhibitor. So
Yes.
what basically they're trying to say that SGLT2 inhibitor is a more efficacious drug in terms of HbA1c reduction. But I have not seen that in clinical practice. I mean, I feel that in our patients, DPP-4 inhibitors also bring about good A1C reduction. What do you think?
Yes. So basically, see, when you are using DP4 inhibitor or AJ2 inhibitor separately, maybe starting with say HbA1c more than 10 or something. So at this point, every whatever treatment you give, the patient sugars are going to come under control with little bit variation in the
Yes.
HbA1c reduction efficacy.
Mm-hmm.
But when you do these studies in controlled environment like randomized controlled trial, then only you will understand how much it's decreased by say DPP4 and how much is decreased by SGLT2 inhibitor.
Mm-hmm.
The recommended or rather the confirmed HbA1c reduction by DP4 inhibitors is around zero point 0.5 to zero point 0.6. It is little bit variable with Vilda and little bit variable with others. Okay, and with HbA1c reduction for HbA2 inhibitors is around zero point 0.7 to zero point 0.8. But in practice, know that if the HbA1c baseline HbA1c is around say 10, 11, then 4% HbA1c drop I have seen with just with the or rather just
Yes,
with
yes,
DPP
yes,
plus
yes.
metformin, and
Yes.
also it's same story with SGLT2 inhibitors and metformin. So basically, these two drugs are very good. And one point I want to make here that when you add SGLT2 inhibitors and DPP4 inhibitors to metformin, the
Uh-huh.
combination is very good and it is something like super additive. Suppose with one drug, say zero point 0.6 with DP4 inhibitors and zero point 0.8 with SGLT2 inhibitors and with metformin around 0.5 to 0.56. But the total is around say only 1.4 to 1.5. But when you use these three drugs together, then you can get HbA1c reduction of say 2.5 to 3 also. So that
Mm.
is what my experience. So when you try to use these combinations early and try to use like three drugs in early stages, then you will get profound and prolonged benefit of HbA1c reduction. And afterwards, you can stop one or two drugs from that group also.
Right, right, right. Agreed. So I would just say that, Empalina combination, it will provide a robust HbA1c reduction and a 2 to 4 times higher odds of patient reaching our A1C target of below 7 with a lesser incidence of hypoglycemia with weight loss. And it will also reduce the daily pill burden in this patient population of ours. And so definitely this combination should be used in our kitty.
Yes, I agree with that. Yeah,
Yeah. Thank you.
thank you.